Current physical activity guidelines recommend resistance training twice a week, yet we have lacked high-resolution data measuring its long-term, independent effect on type 2 diabetes. Prior research often relies on single, static baseline measurements. Because behavior changes over decades, this creates regression dilution bias, which tends to underestimate the true protective effect of exercise. A 2026 prospective cohort study in JAMA Network Open provides a clearer view of this biological defense, focusing on long-term glucose disposal and insulin sensitivity. The analysis was conducted by researchers at the Harvard T.H. Chan School of Public Health to address the gaps in existing lifestyle data. They drew from 3 major U.S. cohorts, including the Nurses' Health Study, with clinical management centered at Brigham and Women's Hospital. The scope of the investigation covers 143,715 healthcare professionals, tracked over an average of 19.2 years, utilizing as many as 14 repeated assessments per participant. This longitudinal approach minimizes the impact of regression dilution bias. By mapping human behavior continuously over decades, the study isolates how specific training patterns actually influence metabolic health. The primary question is whether resistance training offers metabolic protection that exists independently of other factors. Epidemiological data is often clouded by confounders. Individuals who lift weights frequently also maintain a lower body mass index and higher levels of aerobic activity. The study also evaluates a secondary question: does a lifelong behavioral trajectory provide more protection than acute weekly workout volume? We will first isolate the baseline signal, then construct an additive risk matrix, and finally map the midlife trajectory of these habits. This multivariate evidence provides a new technical foundation for how clinicians must prescribe exercise for disease prevention. We begin with the multivariable adjusted baseline. The researchers controlled for diet quality, smoking, family history, and total aerobic activity to find the specific signal for resistance training. This chart plots weekly resistance training against diabetes risk. 2 or more hours yields a 0.73 hazard ratio. Notice the initial drop. Risk reduction appears at under half an hour weekly. Compared to the 1.0 baseline, the total eliminated risk is substantial. Biologically, this reflects the impact of resistance training on muscle mass and skeletal function, which directly enhances systemic insulin sensitivity. However, we must determine if this 27% reduction is merely a secondary result of these participants having a lower body mass index. To be a valid clinical tool, the signal must demonstrate its effect through adiposity cross-classification. We must differentiate the biological role of muscle adaptation from the simple process of weight loss. This chart maps training across 3 BMI tiers. In the obese tier, baseline risk hits a 9.2 hazard ratio without training. Adding an hour weekly lowers it to 8.16. The normal weight tier shows proportional drops. Resistance training uniformly protects metabolism regardless of starting mass. This consistency indicates that the benefits of resistance training are not simply a byproduct of having a leaner body. Lifting weights provides metabolic armor that functions independently of the mechanics involved in total mass reduction. Beyond body mass, we can layer the data into a lifestyle matrix that includes aerobic activity and sedentary time. The researchers used specific thresholds: 15 MET hours per week of aerobic activity and under 2 hours per day of sedentary television viewing. This matrix calculates compound effects, starting with a 1.0 baseline risk block for meeting 0 recommendations. Adhering to aerobic and sedentary thresholds compresses the risk to a 0.52 hazard ratio. Adding weekly resistance training reaches 0.38, a 62% total risk reduction. Resistance training activates metabolic pathways that complement aerobic work, effectively compounding the total protective effect. This specific 3-part combination provides a potent non-pharmacological strategy for metabolic defense. To understand the long-term impact, we must look at the study's longitudinal tracking within the Nurses' Health Study too. Single-point snapshots fail to capture the reality of how exercise habits fluctuate over a midlife span of 20 years. This graph plots 5 midlife training trajectories from ages 40 to 60. The fluctuating group ends at a 1.02 hazard ratio. Intermittent intense training followed by inactivity provides no lasting protection. Conversely, the consistently high trajectory yields a 42% risk reduction. The threshold for this group was just half an hour of training per week. It is a highly accessible volume that yields results because it was maintained for decades. unbroken adherence over time is more critical for disease prevention than the total volume of any single year. We can now synthesize this evidence into a technical protocol for metabolic health. The first rule is to establish a minimum effective dose, 30 to 60 minutes of resistance training every week. The second is to integrate this with 15 MET hours of aerobic activity and less than 2 hours of daily television. The final constraint is time. These habits must be maintained with unbroken consistency across midlife. This provides a measurable, data-driven target for exercise prescription in clinical practice. This data suggests a shift in how both clinicians and patients approach physical activity. Prescribing high-intensity bursts is mathematically less effective than prescribing persistent, moderate habits that never stop. Achieving a 62% reduction in diabetes risk is the core biological outcome of this polytherapy. Preventing metabolic disease does not require elite athleticism, it requires persistence. Resistance training serves as a distinct independent component of metabolic defense, available to anyone willing to maintain the trajectory.